Frykholm. Dr. Frykholm is a consultant pediatric anesthetist at Uppsala University Hospital in Sweden. He's also an associate professor at the Department of Surgical Sciences. His research interests are preoperative fasting in children, how to avoid neurodevelopmental damage from anesthesia in children, and practical aspects of pediatric anesthesia. He is also a board member of the Safe Tots Initiative and the European Society of Pediatric Anesthesiology. Along this line, he participates in teaching missions for Operation Smile and other organizations in the developing world. On a side note, he would like to learn how to play the oud, if anyone's interested in teaching him. Dr. Peter, the floor is yours.
Thank the organizers for inviting me to talk about sedation of children outside the operating room. And I congratulate you for being able to hold this conference in spite of the ordeals that you're going through at the moment. We'll talk about the PROSA concept. We'll talk about risk management, team composition, and a range of methods, sort of tips and tricks of different pharmacological methods. So what is PROSA? Procedural sedation and analgesia. It has 5 goals: to reduce anxiety, minimize pain, reduce psychological stress, immobilize the patient if necessary, and ensure the safety of the patient. And we can use many methods to achieve these goals. So how about safety? How safe is procedural sedation? Well, of course, it depends on the setting and what drugs you use. This is a big study from the United States where they monitored almost 50,000 propofol sedations. And they had a pretty high incidence of airway complications needing interventions, so more than 1%. They analyzed the risk factors and found that if the patient was less than 12 months of age, if they used opioids, and if there was serious comorbidity, the risk of airway complications increased. Fortunately, if there was an anesthesiologist present, the risk increased, or the risk decreased of complications. In another study, which was focused on the fasting before procedural sedation, this multidisciplinary group, they presented this sort of algorithm, but I think their list of risk factors is quite good. So again, you've got infants, and if they have a high ASA class, but also anatomical factors like hiatal hernia and procedures like upper endoscopy, bronchoscopy. And of course, if there were airway abnormalities and bowel obstruction, that would increase the risk of aspiration. I think this list of risk factors is quite useful to keep in mind when you plan your procedure. Interestingly, they found that they could agree on quite liberal fasting regimens. So they would be happy to sedate a child for elective procedures, even if they had had clear fluids or breast milk immediately before. For emergency procedures with lower risk factors, they would be happy to do it even if the child had solid food. If there were more risk factors, they would refer for anesthesia care, and they would apply standard fasting rules, but they wouldn't delay the procedure if there was an emergency. And then they would certainly have anesthesia team there and use ketamine. So what kind of monitoring do we need? Well, obviously, SpO2 monitoring is mandatory for all procedures where the patient might lose conscience or have airway problems. And then you get the heart rate as a bonus. But we increasingly use CO2 monitoring for almost all our sedative procedures. For high-risk procedures, you should, of course, measure the blood pressure too. Now, this device is incredibly useful for CO2 monitoring, since it samples CO2 from one nostril and gives oxygen in the other. You get a perfect CO2 trace, and you'll pick up airway problems or apnea very quickly, much quicker than if you're just using SpO2 monitoring. So this is more and more, I think this is my most important monitor when I do PROSA. But of course, the most important monitor is actually an active pediatric anesthetist that's not doing the procedure, but doing just the sedation. And this is important, especially for high-risk procedures. Now, in textbooks, you all often seen this categorization in minimal, moderate, and deep sedation. But I don't think that's very useful because, as we all know, if you use propofol, for instance, the patients will go in and out of moderate and deep sedation. So I propose that we instead have a sort of pyramid of risk management. So low-risk procedures will be those that you can do without anesthesia team present. For intermediate risk procedures, you would need anesthesiology or an ICU team doing the sedation. And then you've got high-risk procedures where you need expert, specialized pediatric anesthesia. And in the rest of the talk, I'll give you a sort of smorgasbord, or in Beirut, it's a metze of different pharmacological methods that you can combine or use as single drugs. I have to say that it's for the experts to combine several agents. Then we can individualize and we can minimize side effects, but always think about safety. But if you have a sort of systems approach, then you can identify routine procedures where you use a single drug and you keep it simple and safe and inexpensive. And these procedures can be managed without pediatric anesthetists. So here's a list of pharmacological agents that you're all familiar with. At the top, you've got midazolam, ketamine, dexmedetomidine, clonidine, nitrous oxide, and even opioids can be used as single drugs in some cases. And these are some common doses. But often to the right, combinations are very useful because then you get some analgesia, but you don't have to go too high on the propofol or the dexmedetomidine. So one of my favorites is ketamine and dexmedetomidine, but also propofol and ketamine is very useful. Then it's more like general anesthesia though. Clonidine and midazolam, then you can have a child that really goes to sleep for procedures that don't need pain. Clonidine and ketamine is also good, and propofol and opioids. But then again, the risk increases if you're not an anesthesia team. Some low-risk procedures are simple things like difficult IV access in uncooperative children or blood sampling, but also pain-free procedures in the radiology department. Let's talk about sedation in the MRI suite. Obviously, for adults and in adults and older children, you can do it awake. But we increasingly use dexmedetomidine for toddlers. We also use propofol infusion with spontaneous breathing, about 10 milligrams per kilo per hour. Previously, we did all MRI procedures in general anesthesia with sevoflurane and an LMA, or even an ET tube. And this was because there was a shortage of MRI slots. And it's really about the priorities here. If patient comfort and safety is all you have to think about, well, then go for dexmedetomidine. But you'll have some failed procedures. So if you've got a shortage of MRI services, then maybe it's better to go for propofol or general anesthesia. But then you also need a room next to the MRI suite where you can have the recovery and do some inductions. If the main bottleneck is anesthesia services, shortage of anesthesiologists, well, then you should find procedures that you can do without them, like with dexmedetomidine. But can sedation for MRI be performed without an anesthesia team present, just having radiology staff? Well, I think we can say they can. This is a study from Stockholm. They audited more than 1,000 procedures, and the mean age was 34 months. And their sedation protocol included 4 mics per kilo of intranasal dexmedetomidine. And that was administered 30 to 40 minutes before the MRI. And if the child was not sleeping properly, they would top up with another 2 mics per kilo. And these are pretty high doses, so you'll get a child sleeping all day after. And on this slide, you've got the MAD device, which is used for nebulizing the dexmedetomidine. In this study, they had a 93% success rate, which is quite good since there was no anesthesia team present. And they had no serious adverse events. And I have to mention that MRI scans can be done in toddlers even without any sedation, with a lot of preparation. And this is a study from Western Canada where they compared different methods of preparation. And they had an impressive success rate of almost 90% in all these groups. But that takes a lot of work. These are some links to useful sites where you can get tips and tricks for non-pharmacological methods of preparing the patients. Let's talk about this very useful combination. In a study from China, in more than 2,000 echocardiography procedures, they combined dexmedetomidine and ketamine intranasally. And why the combination? Well, sometimes dexmedetomidine is not sufficient alone when you're stimulating the patient and pressing on the stomach. And that's when adding some ketamine is quite useful for more stable conditions. And in this material, with some quite sick children, they had a very low complication rate too. Of course, if the child has severe comorbidities, it is at least an intermediate risk procedure. Then you need a competent procedure team, preferably anesthesia. And that can include longer radiology procedures, radiotherapy, burn stressing changes, oncology procedures, and endoscopy. And also when you go to the emergency department to help out with minor procedures. So how would you deal with a very frightened little 1.5-year-old in the emergency department? There's no IV line, and she's very scared of everyone in scrubs. Well, you can do this in very many different ways. If it's Saturday evening and you've got a full OR list to do, you can, of course, put this child on the OR list for suturing the lip. But if you're like me, you'd probably want to do it immediately. And you can get some support in that consensus statement that the child doesn't have to be fasting. But you have to make your plan, and you have to take all these factors into consideration. The 5 W's that the SafeTOS organization identified. Who's going to do it? If it's you as an anesthesiologist, you have a range of methods. Where are you doing it? It's safer in the OR, but it's maybe less complicated in the emergency department. And what procedure? When will we do it? Do we have to wait for the fasting? And how? For simple procedures, nitrous oxide obviously can work, but for this kind of procedure and patient, I tend to use ketamine, and it's a very safe and fast option. You can use it intranasally, rectally, but sometimes it's actually very easy just to give it intramuscularly. And this is the method we always use when we work in lower income settings, like in burns missions in Africa. So you put the child in mother's lap, and you give ketamine 4 milligrams per kilo through the thigh, and you wait 15 minutes, and then you could do burns dressing changes or fracture immobilization or anything. But in our burn center, we've taken great care to make everything as comfortable as you can. So we have this room with nice paintings, and you've got a big screen for favorite TV programs. And the nurse is doing procedural sedation there without anesthesia services. They will take their time. They will give some dexmedetomidine intranasally, and then also some ketamine rectally, and they'll wait until the child and the parent are ready. But again, in low resource settings, we use intramuscular ketamine. For oncology procedures, we use propofol and some L-fentanyl for sedation, spontaneous breathing, of course. Now, for high-risk procedures, like patients with a mediastinal mass, also neonates, because they have much higher rate of complications, and of course, patients with severe cardiac conditions. Then, well, this is a mediastinal mass, of course. Then I tend to use a dexmedetomidine infusion, 1 microgram per kilo per hour, and then either intermittent ketamine or a ketamine infusion. And this way you can go on as long as you like, and you'll have spontaneous breathing, and you can do, well, moderately painful procedures like biopsies, and you have plenty of time. So this is very useful. Now, a talk on prosa, I have to mention remimazolam, which is, as you probably know, a new drug with a very rapid onset, rapid and reliable clearance, short context-sensitive half-life, and mild hemodynamic effects. And there's a reversal agent available in flumazenil. But it has 2 main problems. We don't have any decent studies in children yet, although they're on their way, especially from China. But also it's a very expensive drug. So I think you do wisely by just waiting for some more experience in pediatrics. So my take-home messages from this talk is that you can use you can implement liberal fasting rules for low-risk procedures. And for high-risk procedures, always use ketamine, sometimes with dexmedetomidine. Now, single drug, non-opioid, low-risk procedures, such as MRI, can be managed by non-anesthesia staff. It takes some education and auditing, but it's very safe. Combinations of drugs are for experts, that is anesthesiologists, and you should look at your whole hospital system and identify procedures that you can delegate to non-anesthesia team. Thank you for listening, and these are some references that you may find useful.
Thank you, Dr.
Thank you.
Peter.